Hi, we're going to talk about obstructive pulmonary disorders, specifically COPD and asthma, objectives, etiology, the patho, clinical manifestations, nursing care, nursing interventions, and the effects of cigarette smoking on the lungs. But specifically COPD and asthma. You can ignore all the other disease processes at this point. So it is one of the top 5 leading causes of death, and it is climbing in terms of deaths and severity. It is a disease that definitely limits function, and everyone is really just trying to manage this disease process because it is progressive, whether it's pharmacological or non-pharmacological needs. So let's talk about COPD. Basically, there's no cure. Once the damage is done, the damage is done. Okay? It can lead to comorbidities, including pulmonary hypertension, and it can also lead to chronic bronchitis, emphysema, or both. And the number 1 cause of COPD is smoking. And for those that just need a little refresher, bronchitis is basically recurrent bouts of coughing with mucus production, and emphysema is the alveoli are actually restructuring, leading to impaired gas exchange. So what are the risk factors for COPD? Well, smoking, obviously number 1. Low socioeconomic status, advanced age, recurrent or chronic lung infections, air pollution or exposure to chemicals and dust, occupational exposure, or sometimes there's some genetics that are related to COPD. Basically, COPD commonly starts to manifest when folks reach the rightful age of 60. Around 1 in 100 people with COPD have a genetic tendency to develop the condition. And basically, that condition is they lack a certain substance that protects the lungs. So without it, they're more vulnerable to damage. You guys don't need to know that, not at this level. I just want you to be aware of some of the certain risk factors for COPD. Okay, so let's talk about the patho, just real quick, down and dirty. Okay, so if you look at page 660, I want you to refer to figure 3113. Basically, it's a chronic inflammation of the airways. Okay, it causes irreversible structural damage to those airways, the alveoli, decreased elastic recoil, reduced airway diameter due to chronic inflammation, okay, increased thickening of the alveoli membranes resulting in poor gas exchange. So basically, you still have the same amount of air that you're trying to get through, but those bronchioles, those airways are reduced, and it's really struggling to get through. Okay, super important that you guys need to know this because obviously there's a star, and I've told you a specific figure and a page number. So let's look at this a little bit further. Obstructive pulmonary disease with progression, limitation in airflow that is not reversible. Okay, I cannot repeat this enough. Once it occurs, once it starts this progress, there's nothing that we can do to help it. However, I think it's important to understand that there's a difference between obstructive versus restrictive lung disease. Obstructive is basically a difficulty with exhaling air. So that's asthma and COPD. And that obstruction can occur when inflammation and swelling cause the airways to become narrowed or blocked, making it really difficult to expel air from the lungs. This results in abnormally high volume of air being left in the lungs, which is referred to increased residual volume. This leads to trapped air and lung hyperinflammation. So if you can think of all this air just being trapped in like a small area of your lungs and it can't be let out, okay, that's really what we're talking about. So restrictive lung disease is actually difficulty filling the lungs with air during inhalation. So you have a decrease in the total volume of air that the lungs are able to hold due to its elasticity of the lungs. Okay? Okay. So let's just kind of work through this a little bit. So as I said earlier, smoking is the #1 cause for COPD. Specifically, what are the direct effects of cigarette smoke? Okay, let's talk about this. Let's break this down. So you have a hyperplasia of goblet cells, which increase mucus, increase difficulty clearing of that mucus, and decrease the diameter of the airway. You also have some wall destruction, some alveoli wall destruction. And then, which is really, really bad, it's just because COPD is so horrible to manage as a patient, but those lung cells can change to precancerous cells. So basically, changes in small airways equals inflammation equals airway remodeling. I really want you to focus on page 657 and table 31.16. So let's talk about the manifestations. These pictures are great, okay? So basically, if you can think of chronic airflow limitation, if you are struggling to breathe, if your patient is struggling to breathe, what's going to happen? Let's think this through. They're going to be so tired they can hardly function, right? If you're struggling that hard to breathe, how many calories do you think that you might need to basically adjust for all of that energy you're burning? Okay, so that's why sometimes COPD patients are super, super thin. They have frequent respiratory infections because all of that mucus is kind of trapped in there because they can't get it out. You have use of accessory muscles to breathe, wheezing, pursed lip breathing, and we'll talk about that in a minute, chronic cough, barrel chest, dyspnea, bronchitis, which with increased sputum, and digital clubbing. So what is digital clubbing? I want you to think about it and think through your head, how can you tell if that has occurred in a patient? Okay? Something for y'all to look up. Okay, so COPD causes dyspnea, right? Inefficient breathing. The alveoli distend and trap air. The diaphragm flattens from hyperinflammation. You have an increased use of accessory and intercostal muscles. Weight loss, anorexia, fatigue, anxiety, and depression. Obviously, it's quite an isolating disease process, rather, just because most of them require oxygen 24/7, and it really limits how much they want to be out and about, right? So that could cause depression. Hypoxemia, hypercapnia, because they can't blow off that CO2, and polycythemia. So what is polycythemia? Well, it's increased red blood cell production as the body tries to get more O2 on board. So the body is working so hard to get more oxygen that it increases red blood cell production. Okay, that's polycythemia. So what are the complications of COPD? Well, you got a bunch here, okay? Cor pulmonale. So pulmonary hypertension, right-sided heart failure. So I really want you to think through, look at this slide, think about what's happening, okay? You can have exacerbations caused by bacterial or viral infections or air pollution. You can have acute respiratory failure, known as ARF, anxiety and depression. So how does COPD cause cor pulmonale? Well, this occurs when low oxygen levels due to COPD cause a rise in blood pressure in the arteries of the lungs. Okay, that's known as pulmonary hypertension. This increase in pressure places excess strain on the heart's right ventricle as it works to pump blood through the lungs. Okay, so let me repeat it. How does COPD cause this? How does COPD cause cor pulmonale? Well, it occurs when low oxygen levels due to COPD cause a rise in blood pressure in the arteries of the lungs. Okay, it's known as pulmonary hypertension. This increase in pressure places excess strain on the heart's right ventricle as it works to pump blood through the lungs. So, what is cor pulmonale? Well, I've got a star here, which means it's super duper important. I've got table numbers and page numbers here to reference it. Okay, basically it's an enlargement of the right ventricle caused by respiratory system disorder. Okay, most commonly COPD with sustained pulmonary hypertension. It's the constriction of pulmonary vessels in response to the alveoli hypoxia. Okay, so you have hypoxia, they can't get what they need, which causes this remodeling. Okay, it seems crazy, but everything remodels, which increases the viscosity of the blood, which is that polycythemia, because your body is starving to make more, get your body more oxygen, right? Management, you need to supplement with oxygen and sodium restricted diet and drug therapy. I really want you to focus on those tables and page numbers that I have listed on this. So how do we know if a patient has COPD? Well, pulmonary function tests, okay, early diagnosis. There's so many things, but basically the diagnosis of COPD is pulmonary function tests. So the goals of treatment, disease prevention, right? We're going to hopefully educate our patients to stop smoking if they have started, and if they haven't, make sure that they know what the consequences could be if they do. Okay. Avoidance of exacerbations, symptom relief, prevention of functional disability. Okay, those are some of the goals of treatment. So what are the medications for COPD? Well, you got a bunch here. And you should know the basics of these. That's all that I'm asking, okay? You have inhaled anticholinergics, which is basically, you have Atrovent, which is the foundation of the treatment, okay? And then you have inhaled beta-2 antagonists, the SABAs, okay? Corticosteroids, that's a really hard word to say. So you have those as inhaled and oral, okay? And then I'm not worried about number 4 and number 5, okay? I don't want you to focus on that at this point. This is not a pharm class. I want you to know the basics of the medications for COPD, okay? So you have the inhaled anticholinergics, Atrovent. You also have the inhaled beta-2 antagonists, the SABAs, and then you have 3, the corticosteroids. So let's talk about collaborative interventions. What can you teach a patient to help them not work so hard? Well, I want you to refer to the pages in the tables that I have on here. So obviously smoking cessation, an exercise plan, nutrition, oxygen therapy, counseling, fall prevention, and follow-up appointments. Okay. One of the things that I should add on here, okay, so let's talk about pursed lip breathing. Well, what is it? Well, it prolongs exhalation, which prevents the bronchioles from collapsing and reduces the frequency of air trapping, which is what you want. Okay. I really want you to look at this table. I don't want to give all the answers away. Refer to this table and then refer to page 666. COPD exacerbations. Well, the frequency increases as the disease progresses, and it's associated with poorer outcomes. I mean, I think that's a pretty logical understanding of the process. It can take weeks for patients to recover. Once again, what medications are you giving them? We just talked about those. Obviously, supplemental O2. Worst case scenario, they may need ICU care, and it can lead to acute respiratory failure. I really want you to focus in on the gerontological considerations for COPD. Okay, at this point in time, they're on page 668. Okay, so let's talk about asthma. Okay, so let's talk about asthma. On average, there's 17.5 million Americans that are affected by asthma. Believe it or not, women are more likely to have it. 38% higher among African Americans. And female African Americans have the highest mortality rates from asthma among any other ethnic or gender group. So I want you to think about why is that, right? There's a lot of health disparity in this country, and this is a perfect example of why that is high for that group, okay? Okay, so what is asthma? I mean, you have friends, you have family possibly that have it. Well, what actually is it? It's a hyper-responsive airway. It's inflammation of the bronchi and the bronchioles. And it can be caused by a bunch of things, okay? I really want you to refer to certain tables, okay? Refer to table 31.3 and page 639. This is a laundry list of some of the risk factors and triggers to asthma. And I'll just repeat them because I'm on a video here. Okay, so genetics, immune response, allergens, exercise, air pollution, occupational hazards, respiratory tract infections, nose and sinus problems, drug and food additives, GERD, and we'll talk about that in just a second. And then there's also some psychological factors involved. Obesity, big factor. So you may have heard about the asthma triad, okay? May or may not have. Basically, there's three things that make patients more susceptible to asthma: nasal polyps, sensitivity to aspirin and NSAIDs, and atopy. Those are your asthma triggers, your asthma triad. Okay. Atopy is basically a syndrome. It's characterized by a tendency to be more hyperallergic than the norm. Okay. A person with atopy typically presents with one or more of the following. They could have eczema, allergic rhinitis, which is basically hay fever, or allergic asthma. And then they can also have food allergies, okay? So basically a triad: nasal polyps, atopy, and a sensitivity to aspirin and NSAIDs. So basically, if you have a patient that comes in with asthma, and let's just say they're having some sort of muscular issues and they ask for NSAIDs such as ibuprofen or Motrin, if they already have a sensitivity, they can have wheezing for maybe 2 hours. I mean, it's really, really, really bad. And there's a lot of research on this particular triad. Okay, asthma triggers. So let's think about how close the stomach is to the lungs. Okay, if somebody has reflux, what do you think is going to happen to all that acid that's coming up and from the esophagus into possibly the lungs? Okay, it may trigger a bronchoconstriction and or cause aspiration. Believe it or not, asthma medications may worsen GERD. So let's talk about asthma manifestations. Okay, I know you guys probably know this, but I'm going to review it with you anyway. Okay, they can be variable: wheezing, cough, dyspnea, chest tightness, runny nose, swollen nasal passages. You also may have nasal polyps. Remember, that's one of the 3 of the triad. Expiration may be prolonged. They could have wheezing, difficulty moving air, and create a feeling of suffocation. Well, this slide has a star on it. Oh, and by the way, the one with the asthma triggers, that's a huge star. So please, please review that. Okay? So diagnostic studies for asthma. Well, basically you have a history and exam, but the key thing that I want you to get out of this is peak flow monitoring. That's how they determine if your patient could possibly have asthma. Okay. They also do pulmonary function tests, also number 1. Okay. So peak flow monitoring, which is every time they come in for a doctor's visit, the physician might be doing some peak flow monitoring, but they're also going to be doing pulmonary function tests. And that's what this peak flow meter really kind of does in a very kind of a easy hospital, well, not hospital, but doctor setting. Okay, so peak flow meter and peak flow monitoring, pulmonary function tests, those are your biggies. Okay, chest x-ray, ABGs, which is, of course, is arterial blood, oximetry, allergy testing, sputum cultures. As nurses, we need to be aware of these tests and what we need to do before and after. So please refer to the tables and the page numbers that I have here. So really, what is a peak flow meter? Well, it's used to check the way that the asthma has affected your body. Okay. It measures how well the air moves out of your lungs. A personal best flow number is the highest peak flow number achieved over a 2-week period when asthma is under control. So let's kind of dig into this a little bit more. And we'll do that here in just a second. But let me go over some of the asthma treatment. Okay, so basically your goal is to achieve and maintain control of the disease. It's classified based on the severity, and you'll see a map here in just a minute. The physician may step up or step down based on what they're finding. And then, of course, there's questionnaires. Okay? Just to throw this out, inhaled corticosteroids are the most effective drug class treatment for inflammation. So let's talk about this. There's a lot on this slide, okay? The SABAs. What are SABAs? S-A-B-A. Short-acting beta antagonists. They're typically used as rescue medications to provide quick relief of asthma symptoms. Okay, they may relieve something that's been induced by exercise. Okay, a lot of times you say, "Oh, I'm working out. I need my inhaler." Patients will tell you that. So that is what the SABAs are: short-acting beta antagonists. Okay. There's certain guidelines that are throughout here, and I want you to look at the different steps, because obviously if they're having persistent asthma exacerbations, you want to teach your patient to walk them through this, okay? Obviously a star on that last slide. I really want you to focus on the asthma action plan, okay? I should have put a star on this. There should be a star on this. I'll make it for next time. Asthma action plan. So why do we have them? It's all about daily management, daily symptoms, how you're feeling, okay? So I've got a figure there and some page numbers there. Asthma is a very progressive, symptomatic illness. You can have great days, you can have really, really bad days, and you could be sort of in the middle. And that's what this asthma action plan is. Green zone, yellow zone, red zone, okay? It's pretty intuitive in terms of, obviously green, you're doing great. Yellow, not so good. Red is, I'm not feeling well, okay? So let's just assume you're in the yellow zone, okay? The yellow zone, the peak flow, that's that peak flow meter that we just talked about, needs to be between 50 and 80% of your baseline. And that can be a little confusing. So the only way that this asthma action plan can work is if you understand what your baseline is. That's what you feel on your very, very, very best days. Okay? You don't have any symptoms. You're feeling really, really good. You don't even hardly remember that you have asthma. Okay? That is your best line, baseline, be active, do what you want to do. Okay? Doctors need to know that. And then if you're not feeling well, that obviously can, your best can feel worst. And that's where these different levels of the asthma action plan come into place. Okay, so let's talk about asthma drug therapy. You have two types. Okay, there's a star in here for a reason. You guys need to know the difference. Two different reasons in terms of why you're taking medications. One, you need immediate, quick relief, okay? Those are the SABAs. Those are the quick-acting anticholinergics, okay? Number two, you have those medications that you're taking on a daily basis to control and reduce inflammation, okay? Long-acting corticosteroids, inhaled corticosteroids, okay? Maybe a combination of different steroids, okay? Anticholinergic drugs affect the muscles around the bronchi, and the bronchi are the large airways. When lungs are irritated, they can tighten, and that's what causes the bronchoconstriction. That's what you're hearing, okay? A reduction of air movement. When you're doing your assessment, you're hearing a reduction of air movement. Anticholinergics work by preventing these muscles from tightening. So basically, they promote dilation, bronchodilation. Short-acting anticholinergic drugs are not used in routine management of asthma except in severe asthma attacks. So let's just say you're having your patient is having a horrific asthma attack. You want a quick-acting relief, such as albuterol, okay? We're going to get more specifics in terms of medications, but you want something specific and you want something to provide quick relief, okay? But if you're talking, okay, every day you want something that's helping to control all the inflammation, you're talking about the long-acting medications, okay? Corticosteroids are a key component of asthma treatment because they reduce bronchial hyperresponsiveness. Okay, they block that late phase response and inhibit inflammatory cell migration. Okay. So let's assume that your patient is having an asthma attack and they've come in, whether you're in the ED, whatever the case may be. Okay. They're restless. They have horrible anxiety. They could possibly have inappropriate behavior, increased heart rate, blood pressure, respirations. I mean, all that makes sense, right? They're super uncomfortable. They are having a horrible time breathing. They're diaphoretic, so they're sweating. They're super, super hot. They're having such a hard time breathing that they can hardly speak in full sentences. They may have a kind of a funky position in terms of how they're sitting up in the bed. Okay, it's called tripod position. Try it yourself. I mean, if you're having a hard time breathing, I mean, I'm hoping that the exams for this class are not perpetuating any sort of breathing issues, but try moving around, try tripoding, because believe it or not, tripoding actually improves aeration, okay? For you or for anybody that's basically having an acute asthma attack, okay? Inspiratory and expiratory wheezing, okay? Huge, huge, huge. Silent chest. Well, what do you think silent chest is? It's a bad sign, okay? You're not seeing any air movement. You're not seeing the lungs up and down. You're not seeing any chest rise and fall. Huge sign. So please look at patient education. Patient education is always going to be huge for nurses, and I want you to refer to those tables that I have there, okay? Okay, so let's talk about some interventions, okay? Whether they have COPD or whether they have asthma. There are certain interventions that we can help that will help decrease a patient's anxiety or panic. Okay, pursed lip breathing. What is that? Okay, they inhale with their lips closed, and then they exhale with their lips closed. Okay, that forces them abdominal breathing. Okay, believe it or not, that really, really helps. We have medications, we're going to monitor them, we're going to auscultate frequently, and positioning. All of these are breathing retraining and airway clearance techniques, okay? There's also airway clearance devices, the acapella, the flutter, CPT, and high-frequency chest wall oscillation. I don't want you guys to focus in on that. Just know what pursed lip breathing does for specifically COPD, and how it decreases a patient's anxiety and panic, and how really it works with how you breathe, okay? Huffing is really important. I want you guys to look at that. If you guys need to look in the index of the textbook, look up huffing. It's important for you to know. Okay, so I have a star on this slide. This is the last slide. What is the first line drug for long-term management of asthma, and why? I'm not going to give you the answers to these. I want you all to look these up. How long does it take for maximum therapeutic effect to be seen with this drug? How often does the client need to take this drug? Can it be used as a rescue drug? And what important information do you need to teach your patients who are taking this drug? What is a leukotriene modifier? I want you to give an example. Can these be used to treat an acute attack? What is an inhaled corticosteroid? And what is it that you need to teach the patient about this medication? This is the last slide, and this is a starred slide. And I feel like I want to give you the answers. Everything tells me I want to give you the answers, but I really want you to look these up. Okay? It's all in the textbook. Look it up, find it, and you guys are going to be great. Okay, that's all I got for you. Bye.